Cardiovascular events kill most CKD patients long before their kidneys fail, making this condition a lethal heart disease in disguise. This chart compares the outcomes for the 800 million adults globally with CKD. Most of these individuals die from cardiovascular events, like heart failure, before they ever reach end-stage kidney disease or dialysis. Because heart disease claims most patients early, tracking a declining glomerular filtration rate, the clinical measure of how much blood passes through the kidney's filters each minute, is an insufficient way to monitor risk. This is the KDIGO 2D matrix. It plots GFR on the y-axis against albuminuria categories on the x-axis. Albuminuria is the leakage of proteins into the urine. It is an independent, lethal vector of disease progression. To reverse this trend, we will map the shared physiological breakdown that drives all kidney disease, the final common pathway, and then apply a triad of pharmacological blockades to halt it. Modern CKD staging dictates aggressive, multi-pathway disease modification. This transitions nephrology from the passive observation of declining function to the active defense of the heart and kidneys. Regardless of the initial cause, kidney disease progression converges on the final common pathway. To compensate for lost tissue, the surviving functional units, the nephrons, attempt to maintain function by hyperfiltering. In this model of a single glomerulus, blood enters through the afferent arteriole and exits through the efferent arteriole. During hyperfiltration, the hormone angiotensin II causes the exit valve, the efferent arteriole, to constrict. By pinching the exit pathway while blood continues to rush in, this constriction creates a mechanical bottleneck. The pressure inside the glomerulus spikes to dangerous levels. This pressure forces large protein molecules through the delicate glomerular filter and into the tubules below. These proteins are toxic to tubular cells. Their presence triggers the deposition of scar tissue and inflammation. Proteinuria is the primary mechanical driver of tubulo-interstitial fibrosis. This scarring is the hallmark of unstoppable CKD progression. The first line of defense is renin-angiotensin-aldosterone system, or RAAS, blockade, specifically using ACE inhibitors or ARBs. These drugs inhibit angiotensin II and force that restricted efferent exit valve to dilate. This immediately vents the trapped blood, drops the internal pressure, and stops the toxic leakage of protein. When you relieve that pressure, the volume of blood being filtered drops. This appears in lab results as a sudden, sharp 30% drop in estimated GFR and a corresponding rise in serum creatinine. This initial creatinine rise is a beneficial hemodynamic effect. It proves the drug has successfully lowered the internal pressure of the kidney, and it is distinct from an acute kidney injury. Clinicians should maintain medication when they see this initial lab dip. The drop proves the blockade is working, and the dose should be titrated to the maximum tolerated level. To further optimize this system, we add sodium glucose cotransporter 2, or SGLT2 inhibitors. Originally developed for diabetes, they are now a mainstay of advanced nephrology. In the proximal tubule, SGLT2 inhibitors block transport gateways, preventing the body from reabsorbing sodium and glucose. These molecules continue to flow further down the tubule. As the excess sodium travels downstream, it hits a specialized cluster of sensor cells called the macula densa. Detecting the high sodium load, the macula densa restores a communication loop known as tubuloglomerular feedback. This feedback signal travels back to the afferent arteriole at the entrance of the glomerulus. It causes the entrance to constrict, reducing the raw volume of blood hammering into the filtration system. This creates a mechanical synergy. ACE inhibitors dilate the exit door, while SGLT2 inhibitors constrict the entrance door, normalizing the internal pressure of the nephron from both sides. Because this mechanism is hemodynamic, the protective benefits persist even when a patient's GFR drops below 45 and the drug's ability to lower blood sugar disappears. SGLT2 inhibitors act as direct structural protectors of the kidney, operating entirely apart from their original role as diabetes medications. We then add a nonsteroidal mineralocorticoid receptor antagonist, or NSMRA, called finerenone, to directly attack cellular inflammation. Finerenone blocks the mineralocorticoid receptor, shutting down the NF-kappa B and TGF-beta1 pathways. This neutralizes fibrosis independent of changes to blood pressure or filtration rate. The primary barrier to combining these drugs is the accumulation of serum potassium, known as hyperkalemia. This gauge shows how potassium levels can quickly rise out of the safe range. Historically, a potassium spike led clinicians to stop RAAS blockade. That decision removes the patient's strongest cardiovascular protection and guarantees the progression of kidney failure. Instead, we deploy novel gastrointestinal potassium binders, like sodium zirconium cyclosilicate, or pataromer. These oral agents capture and clear excess potassium through the digestive tract. Modern nephrology focuses on treating the drug-induced complication. You manage the hyperkalemia so the patient can continue life-saving, disease-modifying therapy. We can now map our multi-target pharmacological triad, RAAS inhibitors, SGLT2 inhibitors, and finerenone, directly onto the KDIGO heat map. In green and yellow zones, clinicians initiate RAAS and SGLT2 inhibitors to preserve nephrons. As patients enter orange and red zones, systemic functions collapse and new therapies must replace the kidney's metabolic duties. At this stage, clinicians must take over the kidney's systemic duties, manually correcting the body's entire chemical and metabolic equilibrium. In stage G4, falling bicarbonate levels cause metabolic acidosis, requiring oral sodium bicarbonate to slow muscle catabolism. Endogenous erythropoietin production fails, requiring treatment for renal anemia with intravenous iron and erythropoiesis-stimulating agents, or ESAs. Phosphate retention triggers secondary hyperparathyroidism, managed through strict dietary phosphate restriction and oral phosphate binders. Stage G4 is the absolute deadline to begin kidney replacement therapy education. If hemodialysis is required, an arteriovenous fistula requires several months of lead time to mature. Optimal survival in CKD requires an aggressive defense of nephrons with multi-target pharmacology, while intercepting cardiovascular fallout before it turns fatal.